Good morning, good afternoon, or good evening, whenever you are watching us. I am Valentin Fuster from New York, and we are in Chicago at the national meeting of the American College of Cardiology, where, as usual, a number of presentations were interesting to all of us, and we are going to discuss the data that has been presented with real experts here. And I'm going to start with my left, Dr. Pamela Douglas, Ursula Gerard Professor of Research in Cardiovascular Diseases at Duke, Dr. Harlan Krumholz, Harold Hines Professor of Medicine, Director of Clinical Scholars Program at Yale University. I don't make any jokes about you yet. And here we have a new person for our program, but very well known. Dr. Josep Rodés-Cabau, Institute of Cardiology and Pneumology at Quebec, City of Quebec in Canada. And now we'll go to the far end. We have Dr. Bob Harrington, Richard Distinguished Professor, Division of Cardiology, Director of the Duke Clinical Research Institute, who is going to leave Duke by July the 1st and going to Stanford University as Chairman of Medicine. Congratulations. We have Dr. James Stein here, Professor of Medicine at the University of Wisconsin, School of Medicine and Public Health in Madison, Wisconsin. And finally, here on my right is Dr. Jorge Plutzky, Director of the Vascular Disease Prevention Program at the Brigham and Women's Hospital at Harvard University. Well, welcome to all of you. What we are going to do, if you agree, we will discuss, see how much time we have, but we will start discussing vorapaxar, which is a new drug, receptor of the platelet thrombin receptor. We will move into the percutaneous valve replacement, the 2-year follow-up of the PARTNERS study. We'll talk about obesity, metabolic syndrome, diabetes, surgical intervention. And I'm not sure we'll have time to talk about off-pump, on-pump coronary artery bypass data that came up. And then finally, we have also the use of CT in the emergency rooms. We'll go slowly and trying to cover as much as we can. And I like to start with the question of the new receptor blocker, vorapaxar, who is an interesting drug. Actually, if we look at chronic atherosclerotic disease, anything that has been added to aspirin really didn't work. And here we have a possibility, is a new approach, and to get into the thrombin receptor of the platelet, a very important receptor, and we have the drug that blocks that receptor. What happens when you add this to the usual platelet inhibition on patients with chronic arterial disease? So this is actually the study. This is the so-called study on the TIMI 50. And TRA2P is the name of the study, and was presented in this meeting by Dr. David Morrow from the group at TIMI. And basically, 32 countries, 1,000 sites, 26,000 patients. I think it's a small sample size relatively to the whole world, Harlan. They had myocardial infarction, ischemic stroke, or peripheral arterial disease, and these patients were randomized into vorapaxar 2.5 milligrams daily or matching placebo with a median follow-up of 30 months. A problem evolved during the trial. I will say to start with that the endpoints, efficacy endpoint was the composition of death from cardiovascular causes, myocardial infarction and stroke. But the number of hemorrhagic strokes on the patients who had a stroke before led to the discontinuation of the study at 2 years on such group of patients. But the study continued on patients who did not have a stroke before. Now I'm going to present the results. At 3 years, the primary endpoint occurred in 9.3% of the patients in the vorapaxar group and 10.5% in the placebo group. So the difference is significant, but we are dealing with 26,000 patients. and it's over 1% difference. Then we have, if we add recurrent ischemic events, which was a secondary endpoint, is 11.2% versus 12.4%. The problem was severe bleeding in 4.2% of patients receiving vorapaxar, with 2.5% of those receiving placebo. And the problem, of course, were the hemorrhagic intracranial strokes, which was 1% versus 0.5%. And even when one look at the group subsequently that did not have a stroke, still there is a significant difference on hemorrhagic stroke, which is of great concern. So I would like to summarize the study by saying interesting approach, interesting drug. Everything looks interesting, but we have to be very cautious. And I like to really open this for discussion. Harlan, I know you're anxious to talk.
Well, I think this is a very interesting study in the sense that here is a drug that Merck inherited from their $49 billion purchase of Schering-Plough. It was what they considered for a long time to be the most promising drug in Schering's pipeline, and the one in which in some ways they were most excited about, projected potentially to be a $5 billion a year blockbuster, because it was going to be able to go on top, a specific thrombin inhibitor, a lot of promising preclinical information and early clinical information, a lot of enthusiasm for it. And then it gets tested. It gets tested in non-STEMI, and with the same issue of coming up, that there's the bleeding and was stopped early in Tracer, which we heard about a year and a half ago, I think, first. Yeah. About
November.
Last November. And now this comes up where the hope was in secondary prevention. They took patients that they thought, well, if we can add this to contemporary therapy, maybe we can help. And again, it's a blow. It does show the expected benefit on thrombotic events, which is good, but the net benefit, which is interesting, the way that they're really reporting it in the paper, they say you take that down, but these are major or severe bleeds. Look at that, and together there's really nothing here that's of benefit. So the question is, are there individuals who might have been at lower risk for bleed but higher risk for thrombotic events that this might be more tailored for? But as far as I could see in their subgroup analysis, they were unable to identify a group that would give me any confidence to say you really are going to have a net benefit from this drug. So I think from the point of view of clinicians, patients, and the company, it was something everyone hoped would pan out. And in the two settings where it's been tested so far, it shows that it can't quite hit this thing of not affecting the bleeds but affecting the thrombotic events. It's reducing thrombotic events but raising bleeds, and patients may be not in a position of having any net benefit.
Bob, I have a question here. Let's assume you're running the company and you say, well, let me change the dose. But it doesn't look promising because the results of the antithrombotic effect are just over 1%. So if you drop the dose, you might even get away from that particular benefit. So how do you feel about overall?
So let me take some of Harlan's remarks and put them in maybe a different context. And here we had a whole new area of biology, thrombin receptor antagonism, that looked promising in the early work. And it looked promising as well because it looked like we might be able to dissociate the ischemic benefit from the bleeding risk. I'd say now we've learned two important things. Number one, we've learned that you can't do that with this set of drugs, that there still is a tight relationship between ischemia and bleeding that needs further evaluation. But the second thing I think that's really important that we shouldn't forget is that on the ischemic side of the equation, I see these data and Tracer as being very similar. Yeah. That Tracer on the primary endpoint didn't make it. It had p-value of about 0.07. But on the secondary endpoint, which is the primary endpoint here, it actually was statistically significant. There was a reduction. So now we have two pieces of evidence that say with this mode of biology, you can make a difference in ischemia. I think they have to re-explore the dosing strategy. Remember, this is an interesting drug. It has a half-life of, dozens of hours. I mean, it's a long-acting drug. The question is it the dose, the dosing interval? How might you think about this over time? Did they treat people too long? If you look in Tracer and you truncate the follow-up of the patients at 6 to 9 months, where some of the other agents have been used, the bleeding to ischemic benefit looks a lot better. So I'm not quite ready to throw it away, Harlan, but what I'm ready to do is say we've learned a lot. This area of biology is important. We think we can make a difference, but there's still some work to do to tease it out.
And just to finish, I mean, I'm not suggesting you throw it away either. I'm just saying in this context, this drug that was so promising has not really fulfilled the promise. Just, you know, as a plug for the large clinical trials, this also shows the importance of studying actual hard endpoints in these drugs. They're going to have to do a lot of retooling to make this drug ready for another large trial.
But you're exactly right. It does tell you that in order to figure things out, you can't do it with hundreds, low thousands of patients.
Pam,
you have to
let me
expose
ask you a
them.
question. We are dealing with chronic disease here, and we have tried lots of things, except the right ones, which is control the risk factors for the disease. We are really going over and over antithrombotics, and I frankly feel skeptical about more and more antithrombotics in chronic disease. What I think we should do is perhaps to shift gears and to try to be much more aggressive in controlling the risk factors that lead to the disease. I only say this to you because after 10 years of thinking in chronic disease, adding a drug to aspirin, still we have not succeeded. That's the reality. I'd like you to comment on it.
Well, certainly in chronic disease, adding clopidogrel to aspirin didn't pan out as a strategy, and adding this maybe might pan out in a subgroup, and they spent a lot of time teasing out pre-specified subgroups, but truthfully they are subgroups. The basics are still the basics, and you need an antithrombotic strategy for people with chronic disease, but it's not clear that having 2 or 3 really adds that much. You also need a lipid lowering strategy, and you need to have that. You need it in all of your patients, or virtually all of your patients. You need a beta blocker strategy in virtually all of your patients. And you can't, you know, adding to one of those strategies potentially at the expense of neglecting all of them.
Well, this is actually the question. Here we have James and Jorge, who are really hot into this issue. James, tell us about how do you view these antithrombotic aggressive approaches versus, you know, the approach to behavior?
Yeah, so my grandfather always taught me that if I didn't want my pants to fall down, I should wear a belt and suspenders. And I kind of look at the antiplatelet therapy as the suspenders, but really the belt is taking care of the risk factors. And I think that the benefit of the antiplatelet therapy increases relative to the risk factor burden. So if the patients are still smoking, if their lipids aren't controlled, if they have a lot of inflammatory stress, the additional antiplatelet therapy may be useful for those people. But if we take care of the underlying pathophysiology that's causing the endothelium to be abnormal, I think we can actually scale back and really just go back to aspirin.
Jorge?
Well, another perspective on this is from the scientific one, which is that in the backdrop of our advances and successes with other therapies, we may be reaching a point where we have to move away from one size fits all with a patient, and that if we could better select the patient who could tolerate the change in thrombotic risk factors and would still have the potential benefit, that might be a group that would really benefit even more significantly. And so I think part of the message in this and many of these studies is that we have to understand patients better, whether it's from a genetic perspective or other risk factors, to know who's going to benefit. But right now, we go into these studies really looking at a fairly heterogeneous population. I think there's real hope in that.
Well, I have a question, and it has to do with personalized medicine here. We are all talking about the group that we select. Let me tell you, after 15 years of trial, demonstrate to me in chronic disease that you are selective on drugs. Just tell me one trial. And what I'm saying is, to me, personalized medicine is fine when everybody's taking the medicines they are supposed to. But we have 80% of the population, we have the data now that they're not taking the drugs they are supposed to, with exactly the same disease that we are talking about this drug. I'd just like you to comment on that.
I'll make 2 comments, one of which is you're absolutely right. We've not figured this piece out yet. And I would say that you know, there's been much emphasis in the community to say, well, you're either taking a population health perspective or you're taking a personalized perspective. I think you need to put them together. That you need to utilize the population health approach to understand the benefits potentially of a new type of science at the population level. But then we have to do the work to figure out who are the patients who may be at benefit, who are the patients who may be at risk of things like thrombotic events. Take one thing that you focused on there, intracranial hemorrhage. So now we've seen this with vorapaxar. We've seen this with other new platelet inhibitors. We've seen it with the factor X inhibitors. How do we figure out who is that group of patients who are at risk for intracranial hemorrhage? The clinical factors alone don't provide all the information. We'd like to think it's old, small body weight people. It's not. And we've got to figure that out. And what if you had a test where you could cull that group out at the very beginning? I think there's some hope for that because we now have big enough sample sizes, unfortunately, of intracranial hemorrhage, where we have the DNA, where we have RNA, where we have plasma. And I think you're going to see some exciting work come forward where people are going to try to sort that piece out.
I don't know, maybe, Josep, I think the future of this is you're going to identify population at risk. That's no question about through imaging technology, through proteomics and so forth. But in terms of the pharmacological approaches, which is what we are talking now, at the moment you have a particular entity like chronic arterial disease, I only want to present to you my skepticism, at least in the next 10, 15, 20 years. That's all what I'm saying about it. So I don't know what comments you have about this issue.
I think that one of the aspects when you look at these drugs that can increase bleeding, I think that if we need to know sometimes much better what kind, for example, of myocardial infarctions you are protecting. I think that it's not the same thing having like huge myocardial infarctions than non-still elevation in myocardial infarctions as a beneficial impact. And we don't have to forget, I think that these patients were treated at the beginning at least with 3 drugs, aspirin, clopidogrel, and the drug of the study. And I would be interested to see if the increased risk of bleeding was related mostly to this first part, and then the patients stopped clopidogrel and were treated only with 2 drugs.
Can we summarize saying this drug needs more work?
I think that would be a fair summary.
Just, Harlan, you agree with that?
I agree, but I also want to reinforce what you said, which is I think the question is that this, are we really going to make that much gain in this whole area versus really trying to focus back on the risk factors and trying to really,
Basics.
the basics.
Well, what about the trial we saw presented at the AHA, Free MI, where even if we give people free medicines, only 10% of them take all 3 of them after their heart attack.
Absolutely.
That's extraordinary.
This is the reality.
Yeah.
Anyway, thank you very much. So we are going to move into the second topic, which is the transcatheter approach to aortic valve replacement. If I recall, at least this is all started about maybe 5 years ago, when the data became to be presented from European colleagues, in which how many patients with severe aortic valve disease are not going to intervention or to surgery. And there were a large number of patients. And the question is, well, this is a very high risk. And then it came the percutaneous approach to patients who would never have surgery. This started, and the results that were obtained were quite interesting, and that is you have a patient at a very high risk that you cannot even intervene surgically. When you compare to treat these patients medically or with percutaneous valve replacement, the winner was percutaneous valve replacement. This was the beginning of all of this. Then came the partner study comparing groups that were at high risk but were surgically feasible. And then they compare the surgical intervene versus the transaortic approach or percutaneous approach with the Edwards valve. And this was presented, I think, about a year ago, the 1-year follow-up of the partners study. And what we had in this meeting is the 2-year follow-up. Interesting. It's so important that we have long follow-ups on everything, because you learn a lot. Well, basically, just to rephrase what many people know about the study, this is a study that 25 centers participated, and was a study of about 700 patients with severe, very significant aortic stenosis and patients at high risk. And these patients were randomized into surgical intervention and the percutaneous intervention with this particular sapient heart valve or the Edwards valve. And these patients were followed for 1 year. This is the data a year ago, and now we have the data 2 years of follow-up. And the data in the first look sounds good. When you have a second look, you begin to worry a little bit. On the first look, mortality is actually the same, 33.9% in the TAVR group with 35% in the surgical group. Fine. Strokes, interestingly, the strokes occurred at the very beginning of the trial on the patients that were treated percutaneously, but it seems that after a while the rates of strokes are small and are the same in both groups. So these are good news. Aortic valve area is very short, continues to be good. There is no significant stenosis, but the problem here is the paravalvular leak. Actually, the paravalvular leak took place in 50% of the patients, which was mild or significant. And one of the problems is this was actually correlated with mortality. I don't know why minor leak leads to mortality, but this is what we will be discussing. But, you know, we have here, Josep, he has been a pioneer in the field of percutaneous valve replacement. And just very short, give us a minute of your whole view of this study, and then we'll go into specific questions.
I think that this study clarifies a lot of things, a lot of concerns that we had about this technology as compared to surgical aortic valve replacement. And as you said, it appears that there are some other concerns that appeared from this data. The first thing is that we demonstrated that TAVR is non-inferior to surgical aortic valve replacement at 2-year follow-up. Despite of this, 1/3 of the patients had died at 2-year follow-up, meaning that this was really a high-risk population, and there's a lot of work still to do in terms of patient selection in trying to improve these numbers and probably trying to improve also cost effectiveness. Secondly, the problem of a stroke is sure a problem in the acute phase. The 3.5% that we observe now in multi-center national registries and even higher in the partner trial is one of the highest stroke rates ever reported in interventional cardiology, much higher than PCI, left atrial appendix closure, etc. We are understanding more and more what's happening. There are immediate strokes and strokes that occur in the subacute phase where maybe atrial arrhythmias play a role. I think that in the future we will try to reduce this stroke rate, but importantly in this trial there was a concern regarding late strokes with these valves. And there were some ideas about maybe these valves are thrombogenic as compared to surgical valves. The paravalvular space we didn't know, and I think that this is one of the most important message of this trial. These valves are not thrombogenic. The stroke rate was during the follow-up there were even less strokes in the TAVR group than in the surgical group. I think that this was also an important message. And then for sure is the problem of paravalvular leak.
Can we stop here?
Yeah.
Because we have to get into that, but I'd like to go into a general view. Bob, what do you think about this study, the 2-year follow-up of partner?
Well, I think that this is a good example of why you need long-term follow-up in areas of chronic diseases. And so aortic stenosis and its either surgical or catheter treatment is not a 6-month or 1-year phenomenon. It's something that the patient is going to have with them for the rest of their lives. And so this is a good example of a new technology. The paravalvular issue had been thought about, but nobody had quantified it in a very careful way. Now we see at 2 years that there's an issue here. And I think that raises some questions. Number one is, how long do you have to follow these patients? Number two, what does that mean? I mean, from a technical perspective, there's some good news here. People will go back with new devices, new approaches, and try to figure out how to limit the paravalvular. But I think it raises another question, is who should be doing these procedures? Because we're seeing an enthusiasm around the country to do these procedures. Do we know enough yet to let it go beyond some very select, specialized centers where people are very good at it?
The FDA is taking a very conservative approach, as you know, because that. But I have a question for you, Harlan. And the question is, I don't understand why a small leak may be associated to mortality, because that's the reality, there's no question about it. And how I don't see as a cause effect. It has to be something else that puts both together. Otherwise, it's hard to understand all of this. And you have a lot of experience in correlations of this type.
Well, I think it's a really good point. By the way, the first thing that really impressed me was this mortality rate. And even among the people with no leak, their mortality rate was, what was it, 24%?
24%, yeah.
So 1 in 4 people are dying. I mean, I was wanting to know, what are people dying of? I mean, if you've alleviated the stenosis, I mean, what are the causes of death in these people? Stroke's okay, but there's still a small percentage of all these deaths. And then, as you said, when I looked at the regurgitation, because even the mild paravalvular leak is associated with increased risk, I think up to 33 or something from the 24. You start wondering, is this associated with something else in these individuals? Is it saying something about the valve or the patient? And it made me suspect that this is a marker perhaps for other things, because I just can't piece it together mechanistically about why it's doing it. And it made me think that they really need to dig into what are the causes of death. There's one other little piece here I think is really important. As people are deciding about this, we really need to be able to provide information about what your life might be like. I mean, we saw some functional status data. We need to know what are the different paths that people may take and the degree to which we can risk stratify people into these different groups. Understanding, is this a marker of something? What is it about these people, so that we can have really informed decisions, is going to be very important.
There could also be the technical aspect of a given patient of how well you can seat, percutaneously.
Well, that's where I would come down with this. The incidence of regurgitation is not anymore in these trials, actually less than has been reported in the registries. This is just the first opportunity that we have of a randomized controlled trial in actually any heart valve. The surgically implanted valves have always been historically compared to historical controls by the FDA for approval, and FDA has not required a randomized controlled trial of any other heart valve. So we're getting an incredible amount of information from this trial on conventional treatment. There's never been core lab adjudicated aortic regurgitation in a prosthetic heart valve before. So even in the control arm, we're doing a totally different kind of research than has been done previously. So there's a ton of information in this trial. The other piece of information that we've touched on is the acuity of the patients. And when you have this much mortality in the control arm, people are dying of things unrelated to the device, because we think our surgical valves are good, right? That's the standard of care. And that is both good and bad. I mean, you want to test something experimental in a high-risk population where if there's harm, you can minimize that as much as possible, and where there's equipoise. But it also means that the high event rate may be more related to the population, which sort of contaminates it and makes it difficult, obscures if there's something related to the valve. Now, to bring that back to the paravalvular leak issue, the patient selection for this trial was very intense, as it is for the core valve trial. And none of the patients are great candidates, right? I mean, we're in a position where none of the patients are great candidates. All of the patients have very heavily calcified valves, aortic annuli. They have a lot of atherosclerosis, hence the very high stroke rate. And there's, it may not be the ideal milieu for any kind of heart valve. There's actually much more regurgitation in the surgical group than has been previously reported. But the patient selection is an issue. The annulus is not round, it's oval. Sometimes it's elliptical, sometimes it's not, and it's very complex three-dimensionally. The device is seated, so there's a patient selection issue. There's procedural issues where the device may be seated a little too high or a little too low, or the bulkiness of the calcium in a particular place may prevent the stent from having a good opposition to the vessel wall.
But this predictor was independent of the gradient, right? It was.
What it was not independent of, though, was coverage area. So the size of the valve relative to the size of the annulus was related to the regurgitation. Things that haven't been looked at, for instance, might be a post-dilatation. Brings a little extra operator risk, but maybe you can, we've learned a lot about how to put in stents, right? And Bob, better than anybody here, you've learned a lot about how to put in stents and how to not put in stents, and underinflation of stents was a huge issue.
I would have two comments. With respect to the aortic regurgitation, I think that we are all surprised. I think that this mild aortic regurgitation was not associated, this is what I know about this, with any left ventricular dilation. We analyzed echo data in a central core lab in Canada about our Canadian experience, serial echoes up to 3-4 year follow-up. Mild aortic regurgitation was not associated with the deleterious effect in left ventricular ejection fraction, no dilation of the left ventricle, as compared to patients with no or trace paravalvular leak. Most of the patients, and we know this from our Canadian experience and others, die because of non-cardiac causes, COPD, chronic renal failure, frailty. These were the three most important factors in the Canadian experience for the patients dying during the follow-up period. And we have to understand that we understand now much more why paravalvular leaks occur. There's a problem of calcium, amount of calcium, and there's a problem with the sizing. We have been sizing with echo. Now we are seeing that maybe sizing with computed tomography, who gives us an idea of the ovality of the valve. We can probably have a better selection of the valves.
Can I ask
in
you
this
a
context.
comment? Well, you are in this business. Now there are a bunch of patients with moderate to significant AR. What are you going to do? Are you going to put...
I don't do this procedure, but I think in the trial what's going to have to happen is the continued follow-up to understand.
No, but yeah, I understand it, but you have to close the leak.
Well, that would be a great question, right? We don't know.
Well, this
We
is the
don't know.
question because
If you're making the assumption that the leak leads to the mortality,
Well, this is where I'm
you might
going
want to
on.
understand if closing it does that. But we don't, I wouldn't say we know that. This is Harlan's point.
Yeah,
That wasn't a good candidate in the first place for surgery.
Yeah, that's probably the
related
case,
to
yeah.
Patient selection.
Yeah.
The valve sizing, so you can't take it out. It may be related to the burden of calcium and atherosclerosis in the patient head to toe that just pans out at the aortic annulus.
Correct me if I think if I'm wrong. This factor of the mild aortic regurg was not evaluated with the other confunders. Was really a factor that was pointed out, but not evaluated in a multivariable analysis. Was really only an observation, because there was a multivariable analysis looking at the baseline factors. Chronic renal failure appeared, low gradients appeared, but this mild aortic regurg was like an observational finding with no really a multivariable evaluation. And we don't have to forget one thing about these valves. These valves perform better than the surgical ones in terms of hemodynamics. Lower gradients and better valves areas. We showed this 3 years ago, and now in the partner trial this was confirmed. There are less patients with prosthesis-patient mismatch. There are better areas, meaning that maybe this problem of mild aortic regurg, that I agree, it's a problem. The calcified valve is left in place.
James, you comment?
Well, I do think that the mild regurgitation is a marker of the type of patient and not really an issue with the valve. It's just not physiologically possible to believe that mild regurgitation, which we see with the replaced valves, is leading to mortality. So I really think it's what Pam said and what Giuseppe said. I also want to point out, though, that the techniques for implanting these valves have improved. I mean, the way these valves are put in 2 or 3 years ago with the first-generation valves, the first-generation delivery catheters, you know, it's a whole new ballgame. So we're already 2 or 3 years behind our knowledge, and people are much better at doing it today. So it's amazing to have this long-term follow-up, but we already don't know what it means for placing them today.
Well, maybe we should move to obesity, which kills more people. Perhaps it's more simple to approach. You're not sure about that, isn't it? No, well, anyway, I think it was worthwhile to get into these, but there's a lot that we have to learn. It seems to me the patients are very sick, and I don't know why these valves are
I think the biggest question to me still is, how do we approach patients who have this problem? How do we consent them? What is the information that we give them? How do we display it in a way that people can understand their alternatives? I mean, it's one thing to say, well, you're going to die unless we do something. Yes. But how are we fairly laying out the pros and cons of this to ensure that we're matching their values, preferences, and goals with the strategy that we're taking, because there is no easy course.
Right.
And I think there are many people who held the idea, oh, just alleviate the obstruction and then they're going to do wonderfully for the next decade. And I think this is showing that it's a lot more complicated, the patients are sicker, and that this is a much more difficult decision than to say, okay, you're blocked here and we just need to unblock you and you're going to do great.
And then the other word of caution is we should not start going into younger people just to avoid the surgery, which has been a thought, certainly in some of the European countries, and this is very troublesome.
This is more than an engineering problem.
Yeah.
That there's a lot more to figure out.
Will there be a trial of that in younger patients?
Yes, in fact, there are 2 trials, the Partner 2, moderate risk, and Surtavi, Partner 2 with the balloon expandable Edwards valve, Surtavi with the core valve in a moderate risk population that for sure will include younger patients with a predicted risk of surgical mortality in between 4 and 8%.
Including bicuspids?
No, the bicuspid is because bicuspids in young patients, if we are talking about calcium, there is a lot of calcium. They will be much more problematic.
Okay, so let's move into a different field, and it's the bariatric surgery. This started, I believe, at least I remember, about 10, 12 years ago. And there was some skepticism because it became a business. Like when the CT machines, everybody was using them, and they lost the power that they are now beginning to come back. But I think what was presented in this meeting is quite interesting to go through and to put this in the context with other studies done. Well, first of all, I think it's not news that patients who have diabetes type 2, over 70% are obese, or certainly overweight. So they both aspects go together. When the diabetes is significant, like it is in the study we are going to talk about, the number of patients that in a reliable fashion control the diabetes is relatively small. It depends on the severity of the diabetes. And in this study, a STAMPEDE study, we are going to present the group, the diabetic group was certainly a high-risk group. Well, let's go into the discussion. This is a study that was based at the Cleveland Clinic and was presented in this meeting by Dr. Philip Schauer. By the way, I ignored mentioning Marty Leon, who is the one who presented the percutaneous valve replacement. He has contributed a lot to this field. So in this particular study, 150 obese patients with uncontrolled type 2 diabetes, they had actually relatively young, an average of 49 years of age, 60% were women. They were randomized into 2 types of surgery. One was bypass at the level of the duodenum and the other was gastrectomy versus an aggressive approach medically. So there were 3 groups, I believe were about 50 in each group. The endpoint of these patients was hemoglobin A1C should reach a level of 6% or less at 12 months. And they really start very high with hemoglobin A1C, so about 7 and 8. So The 150 patients were followed for 12 months after entering into the study, the 3 groups, and the primary endpoint actually was achieved in only 12% of the control group, saying how difficult it is when you have severe diabetes to get into a hemoglobin A1C of 6. And in the surgical group, actually was about 42%. So this is not really high, 42% in the gastro bypass group and 3% in the gastrectomy group, 37%. So we have a study here with bariatric surgery in which you don't really have tremendous results in terms of the primary endpoint. However, it's interesting to look at other aspects, and that is we have weight loss, which actually 29 kilograms and 25 kilograms in the 2 surgical groups versus 5 kilograms. This is a tremendous accomplishment. And certainly the hemoglobin A1C moved very close to 6 in a large number of surgicalized patients, but was an average of 6.6. So in a way, you don't reach the perfect endpoint, but you reach a lot. And I think the study obviously is relatively short, 12 months, and we will talk about this in a moment. But in my view, this is the largest study, of course, and the results are quite suggestive that maybe we have to begin to think about these approaches more seriously. James, I know you're ready to shoot the gun. Right. Give us a summary.
Great. So there actually were 2 articles that were published on it this week, and they were remarkably concordant in showing that people who had weight reduction surgery had a dramatic improvement in their glycemic control, very dramatic weight loss, and buried in the context of all of this is the number of medicines they were able to stop. Almost all of them in the second study were able to get off of diabetic medications, reduce the number of antihypertensives as well as lipid-lowering medication. I feel really strongly about this, and it makes me a little bit unpopular. I think that there are many patients for whom bariatric surgery is the right decision. And 10 years ago, people would have thought I was crazy. Today, people just get a little angry, but there's a kernel of truth here. Once people gain weight, everything that we tell them as healthcare professionals, walk 150 minutes a week, try to eat a little less, for most people, that doesn't work. And most of these people who are morbidly obese are looking at a diminished lifespan, and the amount of time that they have to live isn't a good life. They're disabled, and they have a lot of comorbidities.
Jorge, I have a question. What really goes on here? You lose weight, and the diabetes gets into control. Is an inflammatory process that is control what it is? Right.
It's a fascinating issue, because really what we're talking about here is remission. We're talking about, in a significant percentage of patients, a disease that we think about as being chronic in nature, and you referred to that earlier. It's an incredibly important issue over the lifespan of patients. A chronic disease is going into remission. And there are many, many interesting aspects to it. Actually, the glucose begins to improve before the weight loss occurs. And there's lots of thinking about what the mechanism for that is and whether it involves, for example, all we've learned about gut hormones and the incretin axis, for which there are therapies as well, or is it other issues? And then you get into a phase of the weight loss where that comes into play. I think what's really fascinating about this is not necessarily that we're going to start applying this across the population, but that it really pointing to targets as the culprit of these processes, including the adipocyte, and in particularly the sick adipocyte and the visceral fat. And as people lose weight, and we see in our clinic among those people who do lose weight, things get remarkably better. And in these patients who have morbid obesity, things get dramatically better, including a disease like diabetes going into remission. And I think it points to the adipocyte as a real culprit, and also these other new pathways we're learning about how the gut signals to the brain in terms of satiety.
Let me ask you a question. If I have an overweight patient, mild, but the diabetes cannot be controlled, would you do this procedure? In other words, the patient has a weight that is slightly a BMI, let's say 27, 28, right, and then has significant diabetes. Would you do this procedure?
No.
okay, this is important you comment
Right,
about.
because it's early days. The procedures are not without their risk. I think we have to watch the field evolve. And I also think that as physicians, we're actually not great at achieving weight loss, whereas specialists in this area that exist around the country are actually better at it, with lots of supportive programs and ways in which you can improve weight in patients. And we like
what you said about, and I thought the most interesting thing about this study was that the diabetic control preceded the weight loss. I thought that was fascinating.
To
And
me, it is fascinating.
given that, is this worthy of study, taking people who maybe take a BMI of 31 or 32? Yeah. I mean, they're not at 40. And is it worthy of study, at least in a phase 1, phase 2 type style?
Absolutely. But if someone walks into my clinic and says, sign me up for that surgery, in that kind of scenario, I would want to explore every option to know that we couldn't achieve it through other means before sending the surgery. But it is being
research-wise, did somebody?
And the other thing
that's
interesting.
The answer is not no, but not yet.
Yes, right.
Yeah.
The other important thing is that the preoperative BMI actually does not predict the weight loss and doesn't predict the amount of improvement in glycemic control. So the patient that Val pointed out is a good example of someone who, even though their BMI is 27 or 28, is physiologically as sick as someone perhaps whose BMI is 35 or 40.
That may be because
and that needs to be studied.
How much visceral fat they have.
What about, you talk about
How do you know who's physiologically sick? From somebody who's just overweight.
Well, that could be, things like dysglycemia before you have diabetes. I mean, many of these people had diabetes for 5 years, and to have them going backwards, where we usually say, okay, now you've started anti-diabetic therapy, you're never coming off it. It shows the plasticity of these kinds of issues.
So tell me, if this precedes the weight loss, you talked about in terms of remission, we know we have recurrence too, right? Because there's a certain, despite this operation, people drop weight, they'll go off the meds, they'll come back. What's your thought about what's happening there? Because you've made the mechanical change to the gut. It maybe affected the hormones. Now they've lost weight. Now they're starting to gain weight back.
Right.
Well, when does the diabetes end up, what happens with that when you're seeing that?
Well,
or Jim, you may have seen that more.
It's a complex confluence of many issues, and Dr. Fuster raised inflammation. We know that that's a real driver, that there's inflammatory cells and fat that may lead to the cascade with cardiovascular disease.
But the diabetes will come back.
And the diabetes will come back because we live in an era of caloric excess for our level of activity, and as we overflow our ability to expand fat, it tends to deposit in other places like muscle in the liver and in the visceral fat, and it sets off a cascade of issues. So as you begin to overflow again, it comes back. What I think
you're going to ruin lunch for us, by the way.
What lunch?
Our attitude towards obesity, though, as a society, and even among medical professionals, and we all kind of chuckled when we said we're going on to obesity. We need to kind of change the model. We need to think about obesity as a chronic disease and think about it like we did, alcoholism and cigarette smoking 20 or 30 years ago.
When do you trigger to say you've got the disease? At what do you use BMI, and how do you decide to go to someone and say you've got it now? Because BMI of 29, 30, a lot of people, I mean, that's most of the population.
And there are people who are overweight who are completely insulin sensitive. I mean,
exactly. So I agree with
what
Jorge said.
Jim, in your clinic, when do you decide you're obese?
Yeah, so I look at the pathophysiology. So sure, I use the obese.
Obesity disease.
Well, we don't have any obesity in Wisconsin. But,
all that cheese.
but we certainly look at the body mass index because that's what's used for the criteria, but we pay much more attention to their waist circumference, their fat distribution, and then their triglycerides and their blood sugar and their blood pressure.
So the dysmetabolic syndrome in someone who's overweight.
An easy thing for any cardiologist to think about is to check an A1C, and the ADA says we have pre-diabetes. That's a good marker. If the trigs are up, that's a good marker. And just to pull up now an electronic medical record, have they ever been dysglycemic where their glucose level either fasting or non-fasting was in an abnormal range? I think one of the really provocative things about this kind of study is to what extent can you replicate this with drug therapy? And with drugs that might induce weight loss, including some of these incretin axis modifying drugs.
We are trying to get rid of the surgeons, and they keep coming back. And now they are coming back on a disease that I would never imagine could be diabetes type 2 calling a surgeon.
But one of the things we're now seeing as well with the surgeons is that they're willing to expose their technique to clinical trials.
Yes.
And what I found fascinating about this is that they actually did the trial. I mean, this is not the surgical motto to, they believed they had a procedure. That's right. So I give them a lot of credit for doing it. Now what I hope we see, given the amount of this surgery that's starting to happen, that we do the real outcome study.
Who paid for the study? Is it an NIH study?
No.
I don't think so.
The company.
The company.
Ethicon, I believe.
Right.
Yeah.
Any others?
And it was a single site. I mean, there's a lot of sort of issues that we could talk
It's
about.
pointing the direction.
But it absolutely sends us in the right
It's
direction.
sort of a phase 2.
But we need a big one.
We need the
And
There
phase
is
3.
longitudinal data. You know, the SOS study from Sweden
Yep.
though, showed after 14 years that there's a mortality difference and a cardiovascular disease mortality difference between the two. It's promising, but I think we have this lost generation of people who've gained so much weight that we're running out of things that we can do to help
So
them.
can you say, when do you offer it?
When do I offer it? I use it for my refractory obese patients who have dysmetabolic syndrome, and we really put a lot of effort into lifestyle interventions, which have to be intensive. Once or twice a year telling people to lose weight doesn't work. We've proved it. So we put them in a metabolic rehabilitation program, which at UW is based on the diabetes prevention program. We get very good results for many people, but not the majority of people over the long run. Then we refer them to our obesity clinic where they try some of the fringe things like the very low-calorie diet, some of the other ketotic diets. And then if that doesn't work and they've passed some of the psychological batteries, we think about weight reduction surgery.
Should we use more like visceral fat to decide which patients will respond better than BMI?
I don't know if we know what the
He's
right
personalizing
predictors are.
medicine already.
That's right. I don't know what the right predictors are, but we know that BMI isn't the best surrogate for people's body composition. It's a starting place.
Okay. I'd like to read a statement made by the International Diabetes Federation very recently about
Yes.
all of this. It says, in a position statement released in 2011, the International Diabetes Federation recognized bariatric surgery as an appropriate treatment for obese patients with type 2 diabetes in whom recommended glycemic targets are not reached with available medical therapies, especially when the patient has major coexisting illnesses such as hypertension and dyslipidemia. I guess they're talking about the metabolic syndrome on patients who are rather resistant to the diabetes treatment. I think this is coming, and I think it's going to be quite fascinating.
But you know, part of the direction it's pointing is not only is it coming for these interventions, but it also has to push us to better therapies that don't require someone to have surgery, because that's not going to work for the millions of Americans. You have these issues, you know, 1 out of 10.
1 day procedure.
What's that?
One day
Well,
procedure.
you know, it'll get easier and easier, but I do think that, you know, it also points us to saying, you know, lots of things at societal level of, you know, levels of activity and how much TV you're watching and what, you know.
Better to prevent it before you become obese.
And what's the
also
cost
has
going
us
to
thinking
be
about
and the
the
long-term
physiology
implications of
Yes,
this?
exactly.
And
That's what we
not
learned
just,
from.
ooh, you're fat,
Yeah.
but you have a whole hormonal,
Try to avoid that.
inflammatory, yeah, I don't really want to say that to patients, whole hormonal
Cascade
and
of it.
inflammatory
Yeah, they do.
problem going on here. And I thought it was fascinating, you know, the effect before the weight loss happens, and also the difference in magnitude of the effect depending upon the different surgical procedures, which really gets that there's something mechanistically
Right.
other than the weight loss was exactly the same, but one surgical procedure had twice the effect of the other. There's a lot here we don't
And, you know,
understand.
keep in mind that as cardiologists, you know, we're going to have a wealth of studies coming around about anti-diabetic agents that target, for example, this incretin axis with GLP-1, 2 large studies with the 2 drugs in use, and DPP-4 antagonists that also change GLP-1 levels that may be the relevant gut hormone here. So it really will be in our backyard to think about these
And
issues.
remember, this is not going to be a U.S. issue only.
No.
We're not the only fat country
Right.
on the earth anymore. They're
There's
starting. There's
lots
a
of
big
jobs-
problem.
Lots of jobs now for new surgeons. Because if you look at the rate of obesity and diabetes across the world, maybe we need manpower to take care.
It's a growth industry.
Anyway, what I have noticed during this dialogue, we still have 10 to 15 minutes. What I have noticed is the excitement has moved up from the drug that we discussed at the beginning into the paravalvular leak, and now into the obesity.
I do want to note one thing I heard, really I was impressed by when Jim's approach, really focusing on lifestyle, and then having supportive clinics that you send your patients to. I really wonder if that's also something that could spread across the country, was people really, you know, do more than the twice-a-year recommendations, but there's actually referrals that focus strongly on lifestyle modification.
One of the great advances in cardiology is when we began concentrating our MI patients in one ward in a CCU, because that's where you got expertise from nurses and from doctors and from, you know, support staff. And we have to do the same thing for metabolism.
There are best practices in metabolism. It's not just that it's a failure and lifestyle never works. When we apply the best practices, we can be successful. Again, we don't have 100% success rates, but we have people that do really well, and the best practices come from clinical trials as well as research experiences.
Good. Let's touch into a subject or a presentation, actually two presentations that have to do with cost effectiveness. And I would just, this is basically the use of CT angiography in the emergency room. The presentations were interesting, more than 1,000 patients. One of them was presented this morning, actually, which is the ROMICAT trial, presented by Udo Hoffmann from the Mass General Hospital. And the other is the presentation made by Dr. Harold Litt, who actually led a study from the University of Pennsylvania of over 1,000 patients that came into the emergency room, and is the type of patient with chest pain that you are not entirely sure. These patients today are about, of all the patients with chest pain, only about 20% they really have an acute coronary syndrome across the board. So the question is, can you identify who is real, who is not, with CT angiography? And the results of the two studies were very interesting. They were able to dismiss from the emergency room close to 50 to 60% of patients out within the first 3 hours with a CT that was normal. And then the number of events that follow up really were ridiculously low. So it appears to be a very good approach. I only mentioned this because the figures that they point out is that you can save billions of dollars. I'm not sure this is exactly the truth, but certainly you can save a lot of money because you don't admit the patient, you don't have many hours in the emergency rooms with lots of people involved, and you can send the patient home very rapidly. Harlan, I don't know how you would react to this. I always felt a little skeptical to do a study in the emergency room of this kind, but when you look at the pros and cons, I'm beginning to feel that maybe it's the way to go.
Yeah, I still remain a little bit bothered by the fact that what we're doing is comparing an imaging technique with a usual care, which may not be optimal care. And the question is whether or not a good clinician using good algorithms, I mean, even building on the kind of things Lee Goldman did in the late 80s and early 90s about trying to predict who's going to be, risk stratifying risk for these patients, can decide who needs hospitalization and who doesn't need it. I feel that sometimes we default, if we can just get a test that'll tell us what to do, as opposed to trying to figure out based on what we see, what we hear, what we feel in that information that's available to us, what's the optimal we can do short of that test. And that's not what they tested here. What they said was, we're going to take a bunch of people and we'll get imaging tests on some and we'll let the usual care go on others. And I think that what decides for a clinician, what makes the decision about whether they're going to send somebody in or not, is often a whole range of things. They're concerned about litigation, who they look into the patient, and we haven't provided enough decision support and guidance. People, I'd love to see how this thing stacks up against the very best decision support and the degree to which we can elevate clinical practice short of exposing them, albeit a modest amount of radiation, some radiation, and the cost associated with the test, even though the test costs have come down. And so I would love to see if you could do it without this against the very best practice. But I do see this creep where people are saying, if I can just order this test, it'll tell me what to do and I can decide if they can go home safely. In both groups, by the way, where they send people home, they had low rates. The question is, could they have, in the usual care group, increased the percent they sent home, maintaining low rates if they'd done it using smart approaches short of using imaging?
And remember that in this study, they didn't show that they were saving money. That because that as they got
predict.
the CT angiogram, that led to another whole cascade of events that they go for cath, they go for revascularization procedures. I mean, Pam's running a large study that actually is looking at the question of the different decision strategies of function versus anatomy.
They comment on they stopped testing. I mean, I don't know how deep it is, but I like to comment about what you said. There's no time to think today. Let me be clear. If you go to all the emergency rooms, everywhere I have been anyway, looking at people go for testing right away, and the stratification is fine to put your head there and trying to figure it out, but the world we are today is not where troponins, you were there for a few hours and then you do something else and the patient stays there. You are worried and stays overnight. And this is all over. So I don't think this is going to change.
Yeah. I agree with that. I lament the days where a lot of clinical judgment went into these decisions, but things go fast. What's the ECG? What's the troponin? Let's find a way to get him or her out of here. One of the things that these studies didn't address, which I think is really important, is how uncomfortable we are with uncertainty. And one thing I have to say, when someone gets a CT angio, there's a lot of certainty after that test. You know what their coronaries look like. And the people who get sent out based on good judgment, negative troponins, maybe a stress test, they come back to the ER a month later with chest pain again. It's the same pattern over and over again until they finally get capped. So a lot of people, I think, we're going to save downstream costs by just looking at their coronaries and getting it taken care of.
Harlan, I think simplistic approaches are going to be the future. We make things very complex, and I think in the same, well, anyway, we could talk about so many subjects, but I think simplicity is going to be the name of the game.
But I will say you can automate through the electronic health record decision support tools that are bringing in the disparate information and giving you estimates through these models that are refining clinical judgment.
But they're models, and this is a picture of his heart.
Yeah. So
And this is an acute patient too that you really need to know. You forget about the models and move into the patient.
Yeah, these are TIMI 0 to 2 score, very low risk, negative ECGs or non-diagnostic ECGs, negative enzymes. The trouble is that in our system, and particularly in an emergency room, there's a very different approach to these patients than we see in the office when we see somebody with stable chest pain. They have an acute coronary syndrome until proven otherwise. So there's a burden of proof in an ER patient. It may be exactly the same patient being cared for in an acute setting instead of an office setting because they may not have insurance, because their doctor was on vacation, I don't know, whatever reason they didn't go to the office, they went to the ER. But once they're in the ER, in our healthcare delivery system, the burden is on the emergency room and the emergency room physician to exclude disease. So we have a very different diagnostic goal.
But are we going to surrender just because they're bringing in all sorts of people that don't really have an indication?
Let me finish. We have a different diagnostic goal, and we have a different patient population than other tests. The diagnostic goal is to exclude disease. Most of the time when we do a test, it's because we don't know whether disease is present and we want to rule in disease, right? We are looking for a positive test. In the ER, you're looking for a negative test. So you want to tune the test performance of whatever test you're doing to be incredibly able to exclude disease. And in this case, clinical judgment is not very good at excluding disease on an individual basis. On a population basis, yes, but an individual patient, no. And that's why I would side with Jim on this. An angiogram is really good at excluding disease. A non-invasive CT angiogram is really good at excluding disease, which is what you need to do in these patients. That's the goal. This is not a cost-effectiveness study. This is a cost minimization to achieve that goal of excluding any possibility of having acute coronary syndrome.
But in this very low-risk population, you don't think that a simple effort test should work?
No.
It's a very low-risk people. And we have been doing this in the emergency rooms. You do the effort test, and the rate of events is very low.
Absolutely, and the control arms.
And it's cheaper.
Yeah,
and
no, it's not cheaper.
Not cheaper.
It's not cheaper. And it's not cheaper.
In Canada, maybe.
No, it's not cheaper. Emergency rooms are incredibly expensive places, and they're also incredibly overpopulated, scarce resources right now. And you can have somebody in and out of the ER in 3 or 4 hours, or you can have them stay overnight to rule out for 24 hours and then have their stress test. And the relative cost of a 24-hour admission with a stress test versus a 3-hour admission with a CT is essentially equivalent. And it's that level of efficiency that they were getting at.
This is a very high negative predictive.
Yeah.
And this to me is the key of this.
Negative predictive value in a low-risk population, almost anything is going to have a high negative predictive value.
There's some other gray zone issues with those patients too, because you wonder who those patients who are sent home are going to be in 10 years. And the fact is we've used that hospital setting to initiate and titrate antihypertensives, initiate lipid-lowering therapy, because that is a moment where you get these people's attention. And so, if you really were going to put your your head around costs, you'd have to think about how do we influence these patients who we're trying to see earlier. We often don't see in a cardiology practice earlier, but maybe it's those folks coming through the emergency room, either because imaging said you're not rupturing a plaque, but you've got athero, or you stayed overnight and someone could say, let's titrate up, let's add an antihypertensive. Why is this patient not on a statin?
But let me make a comment about low risk in an emergency room. It's a completely different story than a low risk in your practice.
Yes.
Let me be here, because in the emergency room, 80% of these patients end up going home with nothing. So therefore, by definition, most of the patients that get there are low risk. So this doesn't solve the problem. The problem is still you need to know for your security.
And the emergency room doctor is saying, sending them back and saying, you should really follow up about your blood pressure with your primary care physician, who is the same doctor who hadn't yet initiated anything.
Yeah. We have to finish, but single comment, each of you, of all the discussions we had, what really will stick into you? Bob, you are the first.
That things are never as simple as they seem. That the ideas that we have, don't be wedded to your pretest hypothesis, because many, if not most of the times, you're going to learn something else down the road which should force you to rethink it. And I think every study we've gone through today.
Completely in agreement. I predicted pre-test that you would never go to Stanford, and you are going. The reality.
Because it wasn't that simple a decision.
All right.
Live a healthy lifestyle when you're young, because once you develop coronary disease, once you develop obesity or diabetes, you're in a world of hurt, and there's a lot of problems.
Quite right. Absolutely right.
Diabetes and obesity are plastic diseases. They're reversible. You can put people in remission, and we need to understand them better and come up with better interventions.
Wonderful. Pam?
Well, I'm an imager, so I'll take an imaging viewpoint. It's interesting that so much of what we dwelt on today may be about clinical diseases and clinical outcomes, but a lot of the important mechanistic understanding of what's going on and diagnosing disease and figuring out what to do with it is based on getting pictures of the heart, of the vessels, of the valve, and I think we're going to see more of that over the next few years.
Wonderful.
I think that each of these studies is raising so many questions. We need ways to do research faster, cheaper, better, so that we can fill in the gaps in our knowledge. The uncertainty remains everywhere despite the emergence of these important studies, and the challenge to us is how do we integrate these kind of studies in everyday practice so that we can learn faster.
Intellectually challenging, isn't it?
Yeah.
I would say 10 years ago, Professor Crivier implanted the first valve in France, transcatheter valve, and it's impressive to see the amount of data we have accumulated in this field, but it's also impressive to see how much we have to improve in terms of evaluating better these patients and improving the outcomes of all these things.
Okay, my comment is simple. It was very enjoyable to have you all here. Very, very enjoyable. I think this was a very open discussion, relaxed, straightforward, in difficult aspects that we have dealt with, and that has been really a pleasure to be with all of you. Thank you very much.
Thank you.
Thank you.